we're going to be talking about subarachnoid hemorrhage and delayed cerebral ischemia to present some practical points about this. I don't have any financial disclosures related to this. And the main objectives are just to go over definition of the high-grade subarachnoid hemorrhage, then list all the medical management that is most important, especially at the beginning when the patient presents to the hospital, and then talk a little bit more about how to monitor and how to manage these patients once they are admitted to the neuro ICU. So let's look at a little bit of the highlights of subarachnoid hemorrhage. So I think most of us know about stroke in general. Subarachnoid hemorrhage is classified as hemorrhagic stroke, and it represents about 5% of all strokes when they come in. And the leading cause of the non-traumatic subarachnoid hemorrhage is actually aneurysmal. It's a rupture aneurysm. And we have about 37,000 cases in the U.S. And the major presentation is 55, and women are more likely to experience that. And overall, if you look at the case fatality of all patients, even for those who die at home before they reach the hospital, order of about 51%. About 1/3 of the survivors remain dependent. However, as I'm going to show you, the good news is that once they make it to the hospital, their mortality has actually improved. And another point that is key to remember is that virtually everybody who comes in with an SH will experience a medical complication, and many of these patients are critical. In about 40% of those cases, the complications are life-threatening, so we're really trying to anticipate and prevent complications once they come into the hospital. And these are the most common neurological complications that we're faced with as the patients come in. Delayed cerebral ischemia is present in a significant number of patients. About 1/3 of them will have it. And within that group, 46% will have what we call symptomatic vasospasm. What this means is that not everyone who comes in with the delayed cerebral ischemia will have symptomatic vasospasm. And I think that that's a very important point to keep in mind. Then 20% will have hydrocephalus, will experience rebleeding, 24% seizures, and about 30% hyponatremia. And I think one thing that is important, this is why I bring this slide up here, is that these patients are very complex, and we're constantly dealing with situations where we have significant systemic issues such as heart failure, pulmonary edema, ARDS, hypotension, and at the same time, we're trying to preserve brain functions, and these patients will also have brain edema, hydrocephalus, increased intracranial pressure. So these are very complicated patients. We need to make sure that we know how to treat them well. One of the first things that we do once we assess them and we determine that their airways are patent and their cardiovascular system is stable is that we try to classify them. We're trying to obtain some clinical and radiological scale measurements to try to estimate what could potentially happen to them once they come into the hospital. These are the two scales that we recommend. Currently, clinically, the one recommended is the World Federation of Neurological Surgeons, and this is very easy to obtain because you have the Glasgow Coma scale, and then you have to determine whether they have any motor deficit or not. The grading goes from 1 to 5. What this means is that the lower the grading, the better the outcome of the patient. The higher the grading, the worse the outcome and the greater number of complications once come in. The same thing goes for the head CT grading scale, which is the so-called modified Fisher scale. It essentially is a measurement of the amount of blood present intracranially. So the higher the grade, meaning the thicker the blood, and therefore higher number of complications that those patients will experience. And in general, this is how we classify high-grade SAH. We have a WFNS classification of 3 to 5, which is a clinical classification, and the modified Fisher 3 to 4. The patients have thick blood. Now, as I mentioned earlier, that the good news is that once the patients get admitted to the hospital, the case fatality and mortality has decreased. And as you can see from the slide, from the 70s all the way to the mid-2000s, you can see how the case mortality has gone down all over the world. It doesn't matter which world region you look at. It's a good trend. So whatever we're doing seems to be working for these patients, and we probably keep it up. However, if you look at all the causes of neurological worsening and death, still the delayed cerebral ischemia is a significant um, uh, disease or a significant complication that will lead to worse outcome, and we have to make sure that we try to avoid it or try to prevent it. Now, the key points, in my opinion, during the evaluation of management of these patients is first is trying to follow the established guidelines or recommendations that we have, and we have published recommendations from the Neurocritical Care Society that we should try to follow. And we need to pay attention to misdiagnosis, as we're going to see, the admissions to high-volume centers, early aneurysm treatment, and overall good clinical care following current guidelines. So what about with the misdiagnosis? Well, the frequency of misdiagnosis, it could be up to 50% depending on which site you're working at and which region you're working at. But it's important to remember that most of the time these patients are misdiagnosed because the practitioners fail to obtain appropriate imaging. So the patient may come in, the practitioners may think that the headaches are probably due to migraine and tension headaches, when in fact due to this neurological emergency. And as you all know, migraines and tension headaches will not necessarily lead to death, but subarachnoid hemorrhage will. So we have to make sure that these patients are diagnosed properly. And I think the problem is that when they're misdiagnosed, then they could have more complications and higher mortality rates later. Now, the Canadians have come up with this scale to try to determine the sensitivity to detect SAH using very useful and easy clinical decision-making rules. And as you can see, if a patient is older than 40, has neck pain or stiffness, and has witnessed loss of consciousness, and particularly if the symptoms started during exertion, then chances are this patient most likely will have subarachnoid hemorrhage. So we have to think about obtaining an imaging study on this. Now, we also came up with a diagnostic algorithm that has been available for the past 13 years, and essentially we designed this algorithm thinking of the practitioner in the emergency department, the first responders, to trying to determine how to proceed when patients come into the hospital. So either they do have a typical presentation, meaning severe headaches with nausea and vomiting, dizziness, and decreased level of consciousness, and the head CT will show the subarachnoid hemorrhage to your left on the figure. Then that will be relatively easy. Then you know the patient has subarachnoid hemorrhage, and therefore we will proceed with the workup and treatment of the aneurysm. However, there will be instances where you think, based on the clinical picture, that the patient could potentially have subarachnoid hemorrhage. The pre-test probability is very high, but then the head CT scan is negative. So what do you do in that situation? We're recommending that you proceed with the lumbar puncture and obtaining 4 tubes of cerebrospinal fluid, where you can actually look at the count of red blood cells from tube 1 to tube 4, making sure there's not a significant change in the number of red blood cell count, and also looking for xanthochromia, which is a yellow discoloration of the spinal fluid, in which case it's highly suspicious subarachnoid hemorrhage, so that you will move onto further workup, meaning the patients will have to be admitted to the hospital, and then they will have to undergo further imaging to look for the source of bleeding. If the lumbar puncture is perfectly normal, there's no red blood cells and there's no xanthochromia, then you will move to the right of the algorithm, which means that the patient will probably be discharged even from the emergency department, because patients will not have subarachnoid hemorrhage. Now, this is a typical head CT scan from a patient that has subarachnoid hemorrhage. As you can see, there is significant amount of bleeding. There's the white presence on the CT scan for those who are not that familiar with head CT scanning. And as you can see, there is significant amount of blood in the subarachnoid space. Now, we're going to follow this patient along in the next subsequent slides to see what the patient's outcome actually was. And this was a real case. And then we did an angiogram. This is a 2D angiogram. And as you can see where the arrow is pointing, that's where the aneurysm is. It's an anterior communicating aneurysm. However, it's important that we obtain further sophisticated imaging like 3D angiograms, because those will help us determine the exact morphology of the aneurysm. Like case, as you can see, looking at the 3D, it's a regular aneurysm. It has multiple blebs, and so you can see the anterior communicating artery actually is embedded within the aneurysm. So in this case, most likely surgical treatment will be indicated rather than endovascular coiling, and that was in this particular case. The second point, as I mentioned to you, is about transferring patients to high-volume centers. And I think, in my opinion, this was probably the most important recommendation that we gave during the Neurocritical Care Society guidelines that were published back in 2011. And essentially what this means is that these patients, because they're so complicated and so sick, they really should go to the centers that are specialized, that can actually see, treat these patients, and all the practitioners are actually trained, and they can anticipate complications, and they can actually know what to do with them. So there is already plenty of evidence suggesting that when these patients are admitted to high-volume centers, their outcomes are actually better. The other point that I mentioned to you, which is also important to keep in mind, is the early and adequate aneurysm management. We know from data from more than 10 years old now that patients need to be treated early, so within the first 72 hours. Those are the current recommendations. And if patients present with an aneurysm that could be treated by either coiling or surgical clipping or endovascular coiling, then endovascular coiling is actually preferred. And in fact, these days, I think endovascular coiling is a treatment that is most likely administered to these patients. But either way, I think it's really a multi-professional decision between the neurointensivists, the neurosurgeons, and the endovascular physicians that have to look at the aneurysm morphology, the overall condition of the patient, and to come up with the treatment. And this table here presents some guidelines what those decisions are based on. For instance, if you have a patient who has a poor clinical, an advanced stage, and multiple underlying systemic conditions, most likely endovascular coiling will be preferred in that patient. If the patients have an aneurysm with wide neck to body ratio, then most likely surgical clipping, or if there are normal arterial branches arising from the dome of the aneurysm, or if it is a middle cerebral artery aneurysm, or let's say if you have an aneurysm associated with the large parenchymal hematoma, most likely surgical clipping is recommended. For most cases with posterior circulation aneurysms, particularly top of the basilar, endovascular coiling will be preferred. And of course, you also have to keep in mind patients' preferences. Maybe patients prefer to undergo endovascular coiling, or like the case of the clinical trial that I showed you in the prior slide, if there is clinical equipoise, meaning if the aneurysm could be treated by either method, then endovascular coiling is preferred. When we talk about the general management, this is sort of a general recommendations based on what has been published in general. So obviously, these patients will need to be admitted to the ICU, preferably to the neuro ICU. The first thing is to keep in mind the airway, breathing, and circulation, of course, pain control, GI prophylaxis, DVT prophylaxis, 10 the serum glucose between 80 to 200, and the body temperature within normal limits. And the best evidence that we have are for two recommendations that are in there, which is a calcium antagonist, nimodipine 60 milligrams every 4 hours. It's been shown to improve outcomes. In the past, it was thought that nimodipine would actually prevent vasospasm or delay cerebral ischemia, but it was already shown that it does not. But those patients who are taking nimodipine and present or experience delay cerebral ischemia, they do better when they're taking nimodipine. Same with euvolemia. It's been shown that euvolemia is associated with better outcomes. Let's talk a little bit at the end of the talk here about the delayed cerebral ischemia here for a minute, because we spent a lot of time and many years talking about symptomatic vasospasm and spent billions of dollars in research addressing the symptomatic vasospasm. However, I think a more all-encompassing terminology, I think a better one that has been already agreed on, is the delayed cerebral ischemia, because not everyone will have vasospasm. So you could have other reasons for ischemia, delayed cerebral ischemia after you come in. You could have microthrombi with ischemia of the blood vessels, or you could have embolic events, since these patients have significant cardiac complications so when they come in. But in general, this will be the definition of the delayed cerebral ischemia. The classical symptoms are patients who develop neurological deterioration between days 4 and 14 after they come in. There could be focal findings like aphasia or weakness, or it could be generalized like confusion. And then you have to confirm or rule out the presence of vasospasm or any other condition that could lead to this, like electrolyte disturbance or hypoxemia or seizure or hydrocephalus, rebleeding. All that has to be considered. And in general, this is a classification that's been agreed on about a clinical deterioration associated to delayed cerebral ischemia. Obviously, the focal neurological impairment, it has to last for more than 1 hour, not be present or apparent immediately after aneurysm occlusion, and cannot be attributable to any other cause. And of course, more importantly, is that you have to have a follow-up imaging study within 6 weeks after SAH and confirm that if there is ischemia on that imaging study, that is was not present within 48 hours after the aneurysm was treated. I think that's key when you're considering the final definition or attributing delayed ischemia. Now, how do we monitor these patients apart from the clinical assessment that we do every day on the bedside? In ICU? Well, we have different modalities that are available, and you have the list in there that are commonly used in different institutions. And I think the best evidence that we have for those is actually a transcranial Doppler, and those patients who have mean cerebral blood flow velocity definitely for, above centimeters per second. Those are patients that are likely to have severe vasospasm, are probably highest risk of developing delayed cerebral ischemia. Now, the Lindergaard ratio has been developed and proposed as a ratio of the middle cerebral artery to the extracranial portion of the internal carotid artery. And if that ratio is greater than 6, this also correlates with severe spasm. Now, it's been a lot of debate in the literature about the usefulness of TCD, but most likely it is a useful tool, as been shown in this publication in the Journal of Neurosurgery. It's a high specificity and positive predictive value. So some institutions do. Some institutions tend to use other technologies such as CT perfusion, but I think still the literature is a little bit early and inconclusive as to their real utility. One important point to keep in mind, as has been shown by these studies by Jan Klassen at Columbia University, is that perhaps we use other methods such as the quantitative, EEG, trying to evaluate these patients not only for level of consciousness, but potentially also for cerebral blood flow or cerebral perfusion on these patients. But in general, this is sort of the general management of these patients. We always give them nimodipine, as I mentioned earlier, trying to improve outcome. We have moved away from the traditional triple H therapy, which is hypervolemic, hyperdynamic, and hypertensive. We know that there's more complications associated with that therapy, so we really don't administer that anymore. Most centers now are using what we call induced hypertension, in which case, we try to drive up blood pressures to try to improve the cerebral perfusion pressure and cerebral blood flow. And if the symptoms do not improve within 2 hours, then those patients are usually taken for endovascular therapy to see whether for angiogram to see whether they actually would benefit from endovascular treatment. Now, we have also more recent clinical data from the Himalaya trial that was undertaken in the Netherlands, where it shows that perhaps induced hypertension could also be associated with a significant number of complications. However, the study was underpowered and it was terminated early, in part because of futility for enrollment. So the question is still out there whether this type of therapy actually would benefit. Our patient that I introduced you earlier did develop symptoms referable to the right hemisphere. So the patient developed a right MCA syndrome, and we confirmed with the transcranial Dopplers that the velocities were significantly elevated. The velocities were in the 300 with the Lindergaard ratio of 7, and the patient was taken underwent induced hypertension without improvement and was taken to angiogram. And as you can see where the arrows are pointing to, this patient actually did have a significant vasospasm, both middle cerebral artery and the anterior cerebral artery, underwent endovascular therapy, as you can see, with good results. The patient improved and was eventually discharged home. Now, just to finish the talk, I just want to draw your attention to this table that I think is useful. I mean, it looks a little complicated, but actually it's not. And I want to just draw your attention to the top of the slide, where you can see the sort of the summary of what the things that have been shown more or less to be beneficial, of what things to avoid. It's also they've been associated with worse outcomes. So essentially, you're trying to avoid hypotension, avoid increasing pressure, avoid fever, avoid hypovolemia, avoid all the electrolyte imbalances, avoid anticonvulsants unless the patients have documented seizures, and of course, avoid admitting those patients at volume centers. You should send them to high volume centers. And then we tend to classify them into the color boxes into patients that are high risk versus patients that are low risk. So if you look at the low risk patients, those are the patients with grade subarachnoid hemorrhage, meaning WFNS is 1 or 2, and there is very little or no intracranial hemorrhage of significance. So those patients usually to do very well. They usually go home very early, as opposed to the box in pink, where you have patients in high risk. Those are patients with the WFNS of 3 to 5, and they have very thick subarachnoid hemorrhage on the head CT scan. So those patients tend to stay in the hospital for prolonged periods of time. They're usually in coma or with decreased level of consciousness, usually require mechanical ventilation, and they may end up staying in the hospital for at least 14 days. This is the ICU, and that's the group that has the highest risk for neurologic complications. To conclude, subarachnoid hemorrhage is a neurological emergency. The incidence overall has not changed, but the good news is that the case fatality and mortality have decreased. SAH patients obviously should be treated in high volume centers. I think this is a very important take-home message. And we're still looking for methods to prove the prediction of delayed cerebral ischemia, but I think we should follow the guidelines that have been proposed by the Neurocritical Care Society. Those are available in your materials for the on-call neurocritical care. And always remember, we treat patients. Now, I hope this brief overview of subarachnoid hemorrhage has been useful to you. Thank you.